So when we receive a referral for palpitations, the most important thing is the data that we receive in that referral from the GP. So a clear history, information about their past medical history, the drugs they're taking, any allergies they've got, any investigations the GP's already undertaken in primary care. And the reason we need that is because a small proportion of patients will be referred on to secondary care directly for testing if they're at high risk of ischemia or have got complex past history. About 6% at the moment get advised without needing to see us or have any tests done. Hopefully with increasing quality of information we'll be able to increase that percentage to send more back with advice only. So when we're assessing whether somebody's likely to be high risk of either needing further investigations or likely need a test from us, there are various aspects of the history that we like to elicit. And one of those is there a trigger for the palpitations? How often they're happening, because we need to know what sort of test we might do, how long they last for, if they're associated with any other cardiac symptoms, whether they occur on exertion or at rest, and if there's any previous history that might have increased their risk of having a more significant abnormality. So when we're assessing somebody with palpitations, examination is obviously very important. We need to check their pulse, check whether it's regular, what rate it is, do their blood pressure. We like to know what their weight and height is, because quite a lot of people with palpitations, they're overweight. We listen for murmurs to make sure there's no other structural or functional abnormality in examining the heart, looking for signs for heart failure, which might give us a clue they might need additional investigations as well as the test for their arrhythmia. It's very useful that the GP has undertaken some basic tests before we receive the referral. So one is blood tests, particularly looking at thyroid function, which can be associated with abnormal rhythms. Also the haemoglobin. We see a lot of people with anemia whose the palpitations are due to the fact that their blood count has dropped. A resting ECG, we're not expecting it to show any evidence of the arrhythmia unless they're in an established rhythm like atrial fibrillation, but it's useful to see if there's any electrical abnormalities that give a clue that there might be another structural functional abnormality from a heart point of view. So in our service, probably around about a third to a half won't need a test at all, that their palpitations are due to simple awareness of normal heart rhythm or maybe of isolated rare ectopics. So we're happy to advise those patients after they've been assessed clinically that they don't currently need an investigation. We then have different tools at our disposal. We use 24 ECGs, which we don't tend to use very often because quite often palpitations are less than daily, but if they're happening frequently every day, then it's a high quality test, so it's useful to use that in those people. More commonly, if we are going to do a test, we'll put an event recorder on, which is usually 7 days, can be up to 15 days or even a month with a battery change if required. More recently, though, we're seeing a lot of people who are getting palpitations which sound significant but are occurring less than monthly or less than weekly. And in that case, we would use something like an AliveCor device where we'll lend a device to a patient. They go away for 2 or 3 months with the device and they send us in the traces by email, and hopefully we can pick up a diagnosis that might have been missed on previous investigations. Obviously, in an NHS that's very strapped for both capacity and finance, we're keen to look at other ways of doing things. We're not hugely keen on just open access diagnostics because GPs are very pressurised and they may not have had time to be able to get a full history and assess who is high or low risk. But if we get enough information from primary care and we know that the GPs examine them and they're actually willing to take responsibility for the care of that patient with the diagnosis, we can then arrange for them to have a test done, again with the triage and appropriate length of monitoring or the loan of an device without actually directly seeing one of us face-to-face in clinic. We will then send them a letter which just explains the result of the test, and hopefully they won't then need to come and see us. Obviously, if they're abnormal, we would then bring them in for review. So that's one of the ways we do it. The other way is with the use of the AliveCor devices, loaning devices for patients for anything from 4 weeks to 12 weeks. Again, what that does is it means we're more likely to pick up the less frequent but more significant abnormal heart rhythms that might be missed on previous investigations. So a small proportion of the patients that we see will need to go on to secondary care to have further testing done. If they're getting exertional palpitations, particularly if we see arrhythmias occurring during the day when they're active, they might need to go on, and we quite like the use of an exercise test to see if their arrhythmia gets better or worse when they exercise. Sometimes they'll end up, if we actually pick up something significant on one of our monitors, to go on and have an electrophysiological study to determine exactly where that arrhythmia is coming from and possibly then give them a pathway to actually an ablation to get rid of that irregular heart rhythm. We use sleep studies quite a lot in people with atrial fibrillation because there is quite a strong association between sleep apnea and atrial fibrillation, and we'll sometimes need functional testing because a small proportion of these patients who are high risk end up needing to have ischemia, so some blood supply problem related to their arrhythmia excluded. And so at the moment we have to refer those on, but we're hoping that commissioning will change and that we can have direct access to those tests. So the main take-home message is palpitations are really common. They're around about a quarter to a third of all the referrals that we see in the community. A very small proportion end up being very significant arrhythmias, but those could be life-changing for the patient. So it's important that we identify the patients who are at high risk of having those arrhythmias, picking them up and then treating them as appropriate. The future of either wearable technology or devices that patients can take away, or patient-owned ones, is going to increase the amount of data that we receive. So it's really important that the future of commissioning of investigations for palpitations takes into account all this extra data we're going to have and how we manage that information.